It's great to be here, and thank you everyone for joining us during the holiday season. I hope you're all having a good holiday so far. It's a little chilly, but no rain, but we'll see what happens there. But I want to uh, touch base with you on a couple things. First off, as you can see by our screen, we want to deal with that old age problem and how we can make ourselves move better because, as I tell my patient, life is motion and motion is life, and we all want to stay moving. So that's where I come in, and I'm going to teach you a lot about what we do in making these joints work better with the latest techniques in hip and knee replacements. We'll touch a little bit on the conservative aspect, but tonight I just want you to kind of bring you up to speed on where we are in 2025, 2026 in joint replacements and orthopedics and working at Novato Community Hospital and why it's such an exceptional place to work and why I enjoy working there so much. So, to get started, let's just use the analogy of a car. Those of you who have those aches and pains can relate. It makes a creaking and popping sound every time we set out in it. Well, that's just your knee, sir, as the mechanic says. So, pretend when we talk about joints, we're going to talk about the hip and knee joint, obviously. But when that joint wears down, it's kind of like your joint is a tire. And when the tire wears down, you end up riding on the rims. So that's sort of a simple concept, but it really helps shed light on how we try to treat you and make sure that we get that mobility back. So, what are those symptoms that you experience when your joints hurt? Well, they may be warm or swollen, may have discomfort when you're moving your knees and hips. You may have difficulty standing for a long time or getting up from a chair and have that stiffness or just overall decreased activity. So, you can't do those things that you used to do, and you can't keep up with your friends and play tennis or paddle tennis or pickleball, whichever it may be, but your whole lifestyle is impaired. And you might even notice that your joints look a little bit different. You might be bow-legged or knock-kneed. And here's some pictures of, when you're bow-legged or you've been riding the horse, as I said, your knees end up wearing on one side or the other. And so you can see in the x-ray below, that's the alignment that you get, and it ends up causing pain. So how do you treat that? Well, we either treat it with NSAIDs like Advil, Aleve, Motrin, but you can only take that for so long because if you take it too long, then the stomach doesn't like you, and you end up getting ulcers and discomfort from the meds. So we can try physical therapy as well, which is always a good option when you first start to notice that your joints are hurting because your joints do get stiff, and it's not only the wear and tear in the joint that causes pain, but the capsule that's around the joint can tighten up. So keeping that mobility with physical therapy or even with yoga, Pilates classes, those are always helpful treatment options to push that limitation from catching up to you. Um, Steroid injections. You commonly hear that people go in, oh, my knee hurts, and the doc gave me a steroid injection. It felt a lot better. Well, that's true, but it's short-lived. It gets the inflammation down. I commonly give that to patients who maybe their knees hurt and they're going on a trip and they're like, doc, I can't make it this whole 2-week trip. Can you give me a shot before? Or maybe it's just a single shot and that might help for a whole year. Everybody's a little bit different. And a big one is weight control. Making sure you get that weight off. If you get the weight off, it really makes a difference. It's amazing how much a difference that makes. And the physics are there. So with the weight and the small surface area, if you end up decreasing that weight across a small surface area, the pain does subside. So if all those conservative measures fail and you've tried it all and you have x-rays and that show that you're bone on bone or MRIs or whatever diagnostic that you've had, then we go into the surgery category. And so that's where I'm going to spend some time. So here's one of my favorite postcards a patient gave to me. I think is kind of fun. I can't say I'm entirely pleased with my hip replacement. And but I can guarantee you, you will be pleased with your hip replacement. And this is why. First off, things have changed. In the old days, which is what, 15, 20 years ago, the hospital stays were 2 or 3 days. Now it's Either you come and go the same day or spend one night and leave in 23 hours. It's very common, unless you have lots of comorbidities or medical issues, it may keep you an extra night or two. But overall, 90% of our patients will go home either the same day or next day. And why is that? And that's really because we've had some advancements in several areas, especially in pain control. We have what we call a multimodal pain management with the spinal. So I don't put you to sleep for a knee or hip replacement. I just put your legs to sleep with the spinal. Kind of like when you have an epidural, women for having babies, they'll same idea during birth. We'll have spinals, and we just put your legs to sleep. Now, you're not awake during the surgery. We give you propofol, which is sort of a milky colored substance in your IV and allows you to take a little snooze during a colonoscopy. So you don't see or hear anything. But what's nice is that when you're done and the surgery's over, you wake up immediately. You don't have a general anesthesia hangover and you don't feel nauseous. And so by not feeling nauseous allows you to get up and get going and get moving. So you have a much quicker recovery. We also now have added that you can have juices before the surgery, at least not, within 2 hours of surgery, we allow you to have like a apple juice or any clear fluid that gives you a little bit of energy so you don't wake up with an empty stomach and you don't feel nauseous. So these little tricks of the trade have made a huge difference. Additionally, the incisions are smaller, so less blood loss. Again, as I said earlier, the nausea and vomiting has decreased considerably, which allows you to get up and get moving. And so, this whole concept of taking care of the patient from the time you walk in the door till you head home and the care we have at home, I really call it a really concierge approach. And so, that's really the concept that we carry here at Novato Community. And I will touch on that as well as we move forward. So, what are the techniques that have changed? Well, the three things I want you to remember is this: we've changed the design of the equipment and the design of the implants. We've changed the technique and how we approach. And then we've also changed the materials. So those three things have really jettisoned us into fast forward when it comes to joint replacements. And we have now are able to tell patients, look, when you get a hip replacement or a knee replacement, you're looking at 25 plus years of survival of these. So I joke with my patients, this is good for 100,000 miles. And it is true. You're not going to have to come back in a short time frame and have to take everything out and put it back in again. And I'll explain why that is. But the main thing is that the instrumentation has changed. We have new state-of-the-art operating tables, which allows us to do special techniques and be more minimally invasive. The design, the materials, and the techniques, as I told you, we do 3D printing, and I'll talk to you about that, which I use for knee replacements, and then robotics as well, which is definitely shown big, big changes. Now, I do have lots of people say, now, is AI going to do your surgery? I said, no, it's still me. There's not an AI that's going to be able to do that. I don't think I'll ever see AI in the OR, but we do use AI and other techniques, which has been helpful with literature search and dictations and things in the office and so forth. But you won't have AI operating on you. So let's talk about the hip replacement. And as you can see here, we're recommending a hip hop replacement. And I want you to look on the left of your screen, and you'll see that the hip joint, this is an x-ray of the hip, and you'll see it's nice and round with a space between the ball and the socket. Okay. If you go to the right, you'll see on that x-ray that the ball and socket has collapsed. And so again, using the car analogy, we've lost the tire. So you're riding on the rims. And this is what we call osteo, a little Latin here for those of you who took Latin. Osteo is bone. Arthritis is the wear of the bone. So osteoarthritis. And so the collapse and rubbing of that bone is osteoarthritis. Now, there's different types of arthritis. There's rheumatoid arthritis, which is an inflammatory. There's septic arthritis, which is an infection in the joint that causes septic arthritis. There's post-traumatic arthritis, which maybe you fell off a horse as a child, you injured your hip, and later on in life, your hip hurts. And that's because you damaged the hip early on in life, or you maybe had another surgery or trauma that has led to an arthritic joint down the line. We also have situations in the joint where you can have avascular necrosis, in which the blood supply to the hip joint is lost. And so then the joint dies, and that leads to arthritis. Or hip dysplasia, which is you're born with a socket that is shallow. And so the ball and the socket edge load, and that can lead to arthritis. So, and osteoarthritis. So, we're going to focus on the most common form of arthritis, which is osteoarthritis. And what is a hip replacement? So I'm sure you all have heard about hip replacements and have friends that have probably had it. Maybe you've had one, but it's a very simple concept of reconstituting the hip joint. So we're taking that ball and socket, the hip joint and the head of the femur, and that ball and socket is removed, and we put in a new ball and socket with a socket that's made of titanium. And the stem is made out of titanium. And you wonder why titanium? Well, titanium is metal, and we measure it by elasticity of the metal. It matches bone the most. So you may think, oh, well, my bone is very solid, it doesn't move, but it actually has a little micro motion to it. So if we're going to put a metal inside your bone, as you can see in this picture here, we want to put something that matches the bone. So the one that matches the bone the most is titanium. And so that's why we use titanium. We don't use steel because steel is harder than bone. So if I was to put steel inside your bone, that would hurt very much because it's so hard that the bone can't move around the steel, whereas titanium and the bone move together in one. So that's why we use the titanium. Now, the balls of the hip joint are made of ceramic. And you may ask, well, why ceramic? It would fall down and it would break into lots and lots of pieces. Well, the ceramic that we use is what we call zirconium that's oxidized, and we call it oxinium. And so that oxinium has the smooth surface of ceramic, but it's as hard as steel. And so, again, what I was telling you earlier, these materials play a huge role because we want materials that allow to last a long time. The pariah of an orthopedic surgeon is the fact that if this joint wears, then you're coming back in and I got to change it over again. Well, we don't want to change the tire. We want to leave it in there and have that 100,000 miles that I was talking about. So what we do is we take off the ball and we make a cut in the bone and we put the stem inside. We put a little ball on top of the stem, and that's what we call a tapered fit. And that just slides on in the plastic inside of the socket. And that's what we call a hip replacement. So there are different types of hip replacements. You can come in from the outside, which is the lateral. You can come in from behind, which is a posterior, and you come in through the front, which is anterior. I perform over 90% of my cases. I do what we call an anterior hip replacement. And you may or may not have heard, you talk to your friends, well, what kind of hip replacement? Well, I did the one where the doctor went through the front and he says that's great. Well, they all have benefits. I prefer the anterior because it's an approach that doesn't allow us to have many restrictions for your hip after surgery. So we don't cut muscles through the anterior hip replacement. We spread the muscle apart. We're able to get in and we sneak in and sneak out by putting the hip joint in. With a posterior approach through the back, you have to cut some muscles. But the posterior approach is really the traditional approach that we've all been trained from many, many years. But it's much better for patients that may have a deformity or a revision. But there are many, many orthopedists who like the posterior approach and they do a minimally invasive approach and they have very good results. So I would say that the posterior is very good, but I think the benefit of the anterior is one, it's a quicker recovery, there's less blood loss, you have increased stability and improved accuracy. And I'm going to explain what I mean by that. And also, post-operative restrictions are less with an anterior compared to a posterior. Now, when I talk about improved accuracy, what I mean is that during the operation, I'm able to use an X-ray machine and a navigation equipment. So it's almost like a robotic approach. So I'm always measuring to make sure that the placement of the implants are correct and the leg lengths are the same. We don't want to have one leg longer than the other, or you'll walk in a circle, which isn't a good idea. So I'm a real stickler that you have to be sure that you have your legs the same length. And that's where the benefit comes with being able to check that with an anterior hip replacement. Now, if you look on this screen, on the left, you'll see the incision for the posterior, and on to the right of that is the anterior. And all we're doing is looking at the alignment of the joint coming in from the back or the front. And you can see on the right that I'm using these big instruments in a very small incision. And here is what it looks like inside. So we have all these arteries and nerves and things that we have to dodge when we come in and out. But by sneaking in and sneaking out, we don't damage those. There are risks involved, but that's why you want someone who does a lot of these because they know where everything is and they've been there, done that. And that's why we go to school for so long, so we know where everything is. So here is a video that shows really kind of the whole concept of an anterior approach. So what we do is we make a small incision in the front of the hip, and here are the muscles that surround your hip, the hip flexor muscles like the sartorius and the rectus and the tensor. And we pull those aside, and what we see is the hip joint. And there's a capsule there. So we remove the capsule, and you can see how it's widened. And now I have a clear vision. And you notice I haven't cut any muscles, I've just separated them. And by doing that, I can take a saw, and yes, I use a saw. This is carpentry. And we go in and we make a nice little cut of the bone. And this is how we take the head of the femur off the ball. And that comes out. First, we take a little pie piece so we can get to the ball. And then that is brought out of the joint. Now, once that's done, you have a picture perfect view of the socket. And notice we still haven't cut any muscles. And we sneak in with this little rotating device. It's a reamer that reams down all the spurs and the old cartilage or any wear and tear barnacles, I call it, in the joint. So make it nice and smooth. And then we take the new socket and we tap it in. And when we tap it in, it's what we call a tapered fit because it's going to be just a little bit bigger than the socket. So it fits in there. You wonder, well, how's it going to stay in? Well, we have a coating on the back of the socket called hydroxyapatite that allows for the bone to grow in. This is a special type of table that I use called a Hanna table. And this Hanna table, it allows me to move your leg around in the operating room to get the exposure. So before we go to the second position, we're now going to lower that leg like you saw in the picture. And you'll see that the femur now pops up because the leg is lowered. And now I can work on the other end of the bone. So we've put that socket in, and now we're still in the same incision site. I've moved your leg around, and now I'm taking my new toys and I'm making little cuts. We call this a cookie cutter. And this is the marrow of your femur where the ball used to be. And so what we do is we take these brooches, which are designed, and they're one, two, three, four, all different sizes. As we know, we're all different sizes. So I got to have all the sizes in there, right? Because if we don't, we're going to have a problem. So if you're a 3 or a 4 or a 10, I'll have those sizes in there. And we broach down in the canal to the correct size. Once we get the correct size that we want, we've opened up the marrow. Then we're going to do another tapered fit with a stem that sits in there. We're not using cement like we used in the old days because cement loosens over time. We want something that's going to sit in there, the bone's going to grow into it, and it's going to last. And so that's what we're doing here. If I had cement in 10 years would loosen, then we have to take it out and put a new one in, which we don't want to do. So now we take that socket and the ball and we pop it back in, and you take an x-ray and you can see where it is on the x-ray. And here's the benefit. I can move your leg around in the operating room, make sure it's stable. And then on top of that, I can check your leg lengths. Because again, that's very important. You want the legs to be the same length and make sure that the hip is stable. So that's what it looks like when we do an anterior hip replacement. Now, what do we wear? We wear these funny spacesuits in the OR, which are there to protect us from you and you from us. And it makes sure that it's a very, very sterile environment because the last thing we want is an infection. And at Novato, we are proud to say that our infection rate there is like less than 0.5%, which is very important. So when you're thinking about having your joint replaced, you want it done in a joint replacement center that specializes in joint replacements because we're very keen on making sure that the OR is clean and ready and not having followed an infection that was like a gallbladder removal or something. It's all specific to the orthopedics. And that is a huge win-win for all of us. Now, this is a patient at Novato that, as you can see, she's in her 80s and she's getting up from a seat independently, walking with her walker, turning around, and then she's going to do this on her own and sit herself right back down again. And as you can see, she's in horrible amount of pain. No, she's quite comfortable. And she did all that on her own, and she's only 3 hours out from surgery. And that was a whole new hip replacement. So you can see that the level of pain is very little, well controlled. If anything, it feels like a Charlie horse. And we stay ahead of it. And so she'll spend the night and she'll leave first thing in the morning. Okay. The next topic on hips I want to talk about is called hip resurfacing. And hip resurfacing is an alternative of a hip replacement, which is really a bone preserving type of procedure for the young active male. Now, this is a type of procedure that's limited to males because you need to have a very strong bone stock to have this done. And it's limited to the younger population because it's for that patient who has arthritis at a very young age. So you want to give them something that allows them to have a regain mobility in their hip joint without having to do the full hip replacement. And so hip resurfacing started and was FDA approved in 2006. I've been doing it since then, and in the US, and actually I'm one of the few in the country that do the most hip resurfacing. And it's a terrific option for a patient who is very active and wants to maintain an active lifestyle. And let me show you what it entails. This is actually Derek McMinn. He's the designer of the hip resurfacing, which I went to Birmingham, England, and the design is called a Birmingham, and I trained with him to learn how to put it in. So here's the traditional hip replacement in the video. There's that socket again being put in a liner. Then we're going to put the stem in and a ball on top, and that's the hip replacement. And we went over this and how that is done. Now, how is it different from a hip resurfacing? For the hip resurfacing, what we're going to do, we're still going to put a socket in like we do for a standard hip, but we're going to preserve the bone in the neck and just cap it like a tooth. So we end up preserving, as you can see, you keep your own bone. So that way, when you're a young male and you get a hip replacement, you have this surface replaced with a cap. And then if this were to fail, then you just take the neck off and move forward to a standard hip replacement as if you're getting it for the first time. So it's really a nice bridge for the young patient who has severe arthritis. Okay. And then here is a 28-year-old who had it done, and he was born with severe arthritis, and he's 3 months out and doing some water sports. And here's someone um, kite surfing, and again, a 40-year-old who's had the hip resurfacing. And this next patient, early 60s, and I'll let you listen to the video.
I feel like I can ski like I'm 30 again. So skiing has become just a real joy. My overall health is improved. My movement's improved. I have absolutely no pain. If you'd asked me if I would do it again in a heartbeat, I just wouldn't have waited so long.
And that's pretty much the classic line we always get. Oh my God, I wish I had done this sooner. Right? Because, it hurts for so long and I kept putting it off. Once you get it done, you're going to be thrilled because you get that mobility, no more pain. And it really, when you have pain all the time, it really affects your personality. You can even get depressed. And then you can lead to other organs that can fail because if you're not active, then your heart becomes weaker and you just kind of circle the drain. So it's very, very important to be actively involved, making sure that you address these pain issues, especially if your joints, and especially since there are solutions out there, um, take advantage of it. It's 2025. Okay. So let's talk about knees. Knee replacement, same concept. The knee joint wears down, it's knee osteoarthritis, and what we're going to do is resurface that knee. People say, "Oh my gosh, I got my knee replaced." And you just chop off my knee and put new knees together. No, we're just going to take the ends off, shave it, and place a new part or implant on the ends and cement it on. So this is another great. Are you sure you want to fix your trick knee? This is pretty cool. Haha, very funny. But I do want to show you this picture. This is one of my patients, lovely lady who I did both her knees, and she actually climbed on her own. Well, this is her guide with her, and she went up Mount Kilimanjaro in 2021 with knee replacements. She carried that sign up the whole way and then took her picture. So it was very sweet, and I'm very proud of that. Mount Kilimanjaro on a beautiful day. Okay, so same concept with knee replacements, a shorter surgical time. We want to decrease that blood loss and we want to prevent clots. Okay, high risk of getting clots in the old days of knee replacements. Now we get you up, we get you moving, we do lots of techniques to prevent that. But by having a shorter surgery, shorter tourniquet time, and so forth, eliminates those risks of clots because those are bad. And with knee replacements, we're able to do better alignment techniques, make sure that the implant lasts longer and it's minimally invasive, smaller incision. But not only the incision side, but how we treat the soft tissue below the skin is important so that you have a quicker recovery. So in this video, kind of shows the idea of what does a knee replacement entail and why do you do it? Well, it's when you have pain in the knee joint, you'll see that bone on bone wear. And so the design and the materials and the implants, remember I told you, and the techniques are very important in how we've advanced our techniques in this whole industry. And it's like the knee joint's like a hinge joint, right? It goes back and forth, but it also has a little twist to it. And I'm going to show that to you in a diagnostic computer video that I'll show you here. But this is an angled alignment with a pivot point. And so what we're going to do is take the ends of the knee and we'll shave it off and put on a new implant that is balanced. Now, this is the computer diagram showing how it flexes up and down and rotates. And then this here shows how we shave down the bone and we put the implants on the end and a little plastic in between. And then you now have a new knee. You've maintained your own bone, but we remove just the ligaments on the inside, keep the ligaments on the outside, and you maintain the mobility, but improve it by getting rid of the deformity that you may have had from the wear and tear. You'll see that the black material is that zirconium that's oxidized called oxinium, and it is a longer lasting material. So the wear rate is much lower, and by having a lower wear rate allows us to have an implant that will last longer, and that's the key. You only want to do this once, and we see that with the polyethylene as well. We call it a highly cross-linked poly that's heated to a certain temperature. It allows the bonds last longer in the plastic, and you don't wear. Okay, so that's kind of a simple idea of shows what the parts look like in a knee replacement. Now, one of the techniques I use in knee replacements called PSI or patient-specific instrumentation. And it's a technique where we take a MRI and a long leg x-ray of your knee, the one that we've decided that we're going to operate on because you failed all conservative measures and you've gotten to a point that physical therapy didn't help, injections didn't help, and you're at a point that, okay, doc, I give up. Uncle, what am I going to do? So we decide we're going to get a knee replacement. And so I'm going to get an MRI and a long leg x-ray of your knee. And we design these blocks that are 3D printed, and they're designed and customized just to you to tell me how much bone I should shave off, what position, flexion, extension, rotation. That way, when we make the cuts, they're perfectly aligned. It's just like a carpenter. You want to put that cabinet up. You don't want it tilted. You want it perfectly lined up. And that's how we're going to do your knee. So this is a robotic approach where I'm using the computer to design your implants cuts so they're perfectly aligned. Robotics in the OR, you bring a robot in and you touch the knee and you make sure the alignment is right. With those type of techniques with the robot I've used, but you have to drill holes into the bone. It takes a little longer. There could be accuracy issues. Whereas this way, I come in with my homework done. And I think this is the best approach when it comes to doing your knee replacement. So this is what it looks like. So pretend this is the end of your femur bone, okay, your thigh bone. And these plastic things will land right there on the bone and they fit perfectly. And they're customized only to your knee because we've designed it with the MRI and the long leg x-ray. Then we hold them in place with two screws. And then I take my saw and I make my cut at the top of the bone because this is the cut that I want to make. So it's just the right thickness and alignment. So when it comes off, now you got a nice clean surface. And we do the same on the other end on the tibia. Now notice I'm not using a big jig or drilling a hole into the marrow with these jigs like we used to use. I'm just laying this piece on top and making a cut. Well, how great is that? I'm not having to remove a lot of soft tissue. I'm not drilling into your bone and making it a bone marrow bleed a lot. So this limits the amount of bleeding and it really helps speed up the process as well and get that tourniquet shorter time and allow you to have less trauma to the knee joint, i.e., quicker recovery. And so those are how the cuts are made. Okay.
The surgery itself was as easy as it could be. The knee is fine. It doesn't hurt at all when I play golf. I'm just sorry that the knee couldn't fix my golf game because I'm getting too old to play effectively anymore.
I always love that. She gets that great shot at the end. And, she went back and started just doing some putting at about 6, 8 weeks and delighted with her new knee. So there's a benefit by replacing the knee. Now, do know when you compare hip replacement and knee replacements, hip replacements are a quicker recovery and they don't hurt as much as a knee replacement. I got to be absolutely candid and positive with you. And the way I explain it to patients is, if you have if you jam your finger only goes up and down. And you jam the finger and it gets swollen, it's going to hurt because it only can go up or down. If you jam your thumb, well, it will hurt, but it doesn't hurt as much because your thumb moves in all directions. Well, think of your thumb as your hip joint and your finger as a knee joint. So you have more room for swelling and motion with the thumb and with the knee. And so that's kind of the same idea. Your knees are going to hurt more if they're swelling because it only goes in two directions, which your hip goes in multiple directions. Now, I want to talk about one more item, and that's partial knee replacements. If, same idea, the area of the knee joint is worn down, let's replace just that area. And that's what we call a partial knee replacement. That can either be on the inside, the outside, or even just underneath the patella, which we call a patellofemoral replacement. These also include placement of an implant on the surfaces with plastic in between. It's a quicker recovery because it's less invasive, and we were able to regain that natural knee function. And here you can see in the X-ray where here's a knee where we have a smaller incision. We're going to take care of on the X-ray. You can see the knee is worn down on one side. So since it's worn down on one side, let's just replace that one side, and that's what we call a partial knee replacement. Now, I always love this next slide when we talk about robotics, they've changed a lot. Now, or the old robotics you may remember from Lost in Space. Dangerous Earth people. Now, for some of us, maybe dating ourselves, but we've come a long way from the robot. The robot now and the OR looks like this. It's a little box and a screen. And what we do is we make marks on the knee and we identify where on the knee that we're going to be operating and we tap it and it identifies how much we need to take off and how much we don't need to take off. And then we have it a little device that we hold when we want to drill and remount the bone. And it looks like literally like a little handheld drill. And at the very end is a little tip that comes in and out, and it will tell you when to stop burring and not burring through the bone. So you literally just hold it up to the bone, and the robot tells you, okay, you can burr here, but you can't burr here. You can burr here. And so if you hold it in a different area, it will keep burring. If you go outside the boundary, it just stops. So it's pretty cool on how these things are designed and where we're coming when it comes to surgery. And so we make our little implant areas where the device is going to lay, and this is the tibial one on the floor, and then the other side, and these are cemented on with those little pegs, and we cement those on like that. And there you have a new partial knee replacement. So that is what it looks like when we talk about hip and knee replacements. Now, when it comes to getting your hip or knee replaced, the question is, where do you get it done? As I said earlier, it's good to get your knee done at a facility that is caters to doing joint replacements. You don't want to go to a big university setting where you got 1,000 people coming and going, and you've got, maybe I'm big on training, but you got to remember you'll have a lot of residents working, or you may be following a room that may have had an infection, and the follow-up care. It's good to go somewhere where you have strict protocols. Everyone from the beginning to end knows everything about you. And again, that's really a nice concierge approach that Novato, I think, caters to all the patients. They understand who you are, what you are, and we talk to you even before, the process. And then talking about the process, let's say you're coming to me and then we've decided, okay, Dr. Callender, we got to get this hip replacement done. Okay. So we sign you up, we get a date, but during that process, Novato Hospital is also going to talk to you. They're going to say, okay, who do you have at home? Who is there to help you? Who's going to drop you off and pick you up? Do you have throw rugs? What's your floor look like? We go through all the specifics. How many stairs do you have? What are your medications? Make sure that you've seen your primary care. Do you need to see a cardiologist? And so by the time you get to us, we know what you're allergic to, what your medications are, who's helping you. And so there's no question mark. And then we go into the operating room and then you come out and then physical therapists, they all know about you. And they're going, okay, John, we know where you are. We got at home, you've got 20 steps. We're going to work on stairs, so forth. And then when you go home, we'll have a therapist come to your house for the first 2 weeks and they're going to work with you. And then you're going to be again outpatient physical therapy. And that will be done and organized ahead of time. So one of the nice things about Novato is it's a smaller hospital. With a smaller hospital, you can really build nice protocols and make sure that the nurses and the physical therapists, the doctors, the anesthesiologists, all are on the same page. And we all communicate very closely and we make sure we don't let people fall through the cracks. And we also like to follow up with our patients. And we have at Novato really become the template for all of the Sutter hospitals when it comes to joint replacements because we've won several awards. We're the top 5% of joint replacement centers. We've won the health grade awards out of 3,000 hospitals in the country. We're the top 50, which is amazing for little Novato Community Hospital. Who would have thunk, right? But we also follow our patients very closely, and you can see on here how are our patients doing. So with passive range of motion, we look at the top part is for hip, and the bottom column are for knees. And you can see with comparison to the country, which the average is 85, our patients are at 96 in their points with overall scores when it comes to measuring their outcomes and their satisfaction and improvement. And we can do that as well, looking at the knee scores. Again, we're above the average in the country, and we're at 77.9 here at 2 to 4 months, and at 86.1, which is amazing at the 1 year follow-up. We follow our patients, make sure that they're really happy, doing well, and their outcome. So that's really great to see. And as I said, Novato is a 5-star recipient for the 2023 and again in 2024 and 25. Amazing rewards, but awards in doing their work as a joint replacement center. I want to share with you, I had a patient who I worked on her knee and her hip, and she sent me this cute video of her working at the Academy of Sciences. And so I want to end with this, that it's just such a treat to be able to take care of my patients and make them feel better. And that's what we're here for. And it's a thrill for me and it's a delight to take this opportunity. And thank you for taking your time to spend with us this evening.